just introduce both speakers before we move on to the proper debate. So I have Dr. Merlin, who is an infectious disease physician from Amrita Institute of Medical Sciences, to talk on the side of infection control officer based program, IPC program. And I have Ms. Akanksha, who is the chief nursing officer and for a group of hospitals of Aster in the GCC, and she has extensive experience in managing infection control nurses and infection control programs under various hospitals which she used to supervise. And she'll be talking about the pros and cons of having the nurse-driven infection control program. With that, can I invite Dr. Merlin to share her slides and start the debate, please?
To Taho and Dr. Anup sir for having me for this heated debate on this heated evening. So I'll be, to start with, let me start with the disclaimer that I always believe in teamwork, and I always believe that nurses form a strong foundation and backbone of our infection control program. So, but I'll be purely focusing on the governance part of the program. And as we know that leadership in IPC is a key driver for its success, and I strongly vouch for infection control officer led IC team at this part of the decade as in this debate. So as we all know that infection control officer is a trained clinical microbiologist or an infectious disease physician or a physician with infection control training who develops, implements, evaluates the policies and procedures for decreasing healthcare infections in hospitals. Now, I would like to sensitize you all to this particular publication in AJIC in 2022, which was done in the 50th years of EPIC. So we know that EPIC is dedicated to its efforts in infection control, and they have actually made recommendations for change in infection IPC programs and practice in 14 realms. And these are the 14 realms that they have highlighted. And I would like to take your attention to some of these realms which has been recently added to infection control programs. And these are very vital that this has broadened the scope of the programs. So the IPC that we see today is not the traditional programs which just encompasses hand hygiene, surveillance, the HIA surveillance, the VAE, the SSI, or the CLAPSIs. So it has, the outlook has broadened and has entitled the inclusion of diagnostic stewardship, antibiotic resistance organisms, environmental contamination, including construction strategies to be taken during construction renovations, and emerging pathogens as well. So in fact, IPC has shifted or has become more inclusive towards patient safety and quality as well. So in this aspect, I would like you to think how infection control officer can make a change. Most of these would require strategic inputs from a trained infection control person, which could be either a clinical microbiologist or an ID physician. And a strategic inputs, although the nurses form the foundation of the program, the strategic inputs and decision making from them could be lagging in this aspect. So I would like to take you to this part of this publication, which actually summarizes the differences between the infection prevention programs of 1970s to early 1990s and the infection prevention programs of 2016. So just, the scope of the program itself has been widened to focus on quality and safety outcomes. And I have highlighted something in the lower part, which is the outbreak investigation and control. Now, they themselves have committed that in the earlier era, this has been dependent upon basic epidemiological methods. However, now they have increased in complexity, and the molecular epidemiology, due to the inclusion of the molecular epidemiology and the newer diagnostics as well. And it is out of this debate to say that this requires the expertise of somebody who is trained in infection control and practice. So what we really need to think of is whether we need an IPC program or whether we need a high performing IPC program. So what do we need for a high performing IPC program? So we need the staff education, evidence-based policies, procedures, real-time surveillance. However, the outbreak management is very crucial, and one of the main crucial things is the antimicrobial stewardship. Now, the antimicrobial stewardship, even though viewed, has not been viewed very, hand in hand with infection control program. Actually, it has become a vital aspect of successful infection control programs. So only when antimicrobial programs are integrated into the infection control programs, and appropriate monitoring of the antimicrobial agents can be done, and the patterns, the tracking of the patterns become more effective. So this would be, all these can be materialized, and things will be different when you have an infection control officer in charge. How does the difference come into effect? Now, the clinical decision making becomes a strategic decision making, and the time to the decision making becomes much shorter and more effective. And when an infection control officer is in charge, the multidisciplinary integration that actually drives infection control will be more effective, and this will lead to enhanced governance, and the reporting will lead to more actionable items. Now, as stated earlier, when an infection control officer is in charge, the program will show better alignment with the AMS program, and this is vital for the success as well. And as stated earlier, the improved outbreak response needs an infection leadership from infection control officer. However, NAS-based systems were also able to, do outbreak control. However, this will take more time. They would need more expert opinions. They may not be trained to diagnose, to do, the outbreak evaluation and the outbreak identification based on diagnostics, especially when the outbreak occurs in settings where there is HVAC disruption and there are a lot of clusters of IFIs with increased fungal biomarkers. You cannot expect a nurse-led system to impact the change in these situations. I was just suggesting an example. And also, the ICO-based systems will support research and drive interventions better. Now, there is the pros as the cons of it will not be complete without myself highlighting the bias or when the infection control is under a nurse-led leadership. So there can be always conflict of interest between the oversight and implementation, because in the nurse-led system, the person who oversees and person who implements at a grassroots level will belong to the same system, and there could be conflict of interest in this regard. And this can lead to risk of diluted objectivity in root cause analysis. Whenever they do a root cause analysis for CLABSI and COTI, the missed events, the attributability to the missed events may be, diluted, because they are responding to they are reporting to the same system. And also the clinical integration and the physician engagement. So the infection control requires engagement of all healthcare workers, including the physicians, paramedics. In a medical college, you would have the students. So this wider range of clinical integration and engagement would not be possible, I believe, would not be possible with a nurse-led system. There could be underrepresentation of a nurse-led system in strategic hospital decision-making, especially in aspects where in designing the antimicrobial policies, implementation of antimicrobial policies, implementation of the designing of the hospital infrastructure as well. Now, finally, I will end with the statement that there could be an inertia of cultural change, because the cultural change of infection control always has this cult of patient safety as well. And this requires a broader attention to a lot of stakeholders. And if it resides in a single vertical, there could be substantial inertia to cultural change as well. So I would like to end here, and I would like to take the counterpoints from Mrs. Akanksha. Thank you.
And thank you, cohort, Dr. Anup, and thank you, Dr. Merlin, putting your point forth. And so before we go into this battle of, who should, the epic battle, I should not say epic battle, okay, it's a friendly debate on structure of IPC program, whether who should lead this. So I have a disclaimer. And disclaimer is all arguments in this presentations are properly sanitized with facts, logic, and little touch of humor. So, ladies and gentlemen, please have your gloves off, professionally and respectfully. As said in the infection control program or in hand hygiene, for the hand hygiene, we don't shake the hand, okay? But we are not going to fight also. We are going to make it better. So let's see how we are going to make it better. As Dr. Anup has said that, yes, Akanksha, you have a challenge to change the opinion of the people. Hope I'll able to change the opinion of the people. So I want all of you to think, when you or your loved one is in the hospital, whom will you trust when it comes to prevention of infection? Is it a nurse or infection control officer? Think that. Later on, you give me the answer. I know many of you will say that, yes, Akanksha, we will trust the nurse, because nurse washes her hand in front of us 100 times. She's there who is touching us 100 times. So definitely the way she takes care of us, or the way she handles the infection control, we will be believing in her. But these are emotional talks. Akanksha, we need facts. So here are the facts. All of us, we know the HI is the top cause of the patient's mortality and morbidity, and 7 to 10% of the hospitalized patients in developed countries are been victimized with HIs. But a study by the CDC found that hospital with strong nursing leadership in infection control reduces HI by 30 to 50%, particularly bloodstream infections and ventilator-associated pneumonia. A 2021 systemic review published in the Journal of Hospital Infection showed that nurse-driven hand hygiene program increased compliance rate from 40 to 85%, leading to significant drop in MRSA and C. difficile infection. Here we go. It is a multifaceted impact of nurses in infection control. Nurse leading infection control, you will have a fewer infection, lower cost, and better patient outcome. Now, when it comes to the nurses are the frontline defenders, but I can say that they are not only the first frontline defenders, but they are a last line defense. You imagine in the battlefield, when there is a war going on, the soldiers which are there fighting with enemies, known and unknown enemies. And then there is a general who is sitting and making the strategies. Whom will you trust? The soldiers who are fighting it for the infection, for the saving the life of the people, or the generals who are the strategists? Because usually strategies without executions are hallucinations. And the same here in the hospitals, when nurses are there on the front line, actually they are there with in the bedside monitoring infection at risk. who stop infection before they become outbreak. As rightly said by Dr. Merlin, that outbreaks are very important to control it. But when we want to control the outbreak, all the analysis and everything can happen later on, but we need on-ground execution at that time. Isolations of the patients or cleaning and disinfection, so many things are there. And who runs that? These have been run by the nurses who are there on ground. Or imagine an ICU, a baby gets infection. Who runs? Who identifies the first signs and symptoms of or the early warning signs of the patients when it comes to the infection? Obviously, it's a nurse. So when doctor forgets, as rightly said by Dr. Darshana, no, they want to empower their nurses to sanitize, or no, to give the reminders to the doctors on sanitizing their hands before touching central line, or before touching the patients. Who does that? It's a nurse. So whatever we have a strategy, if nurse doesn't execute it on ground, all the infection control strategies are going to fail. So that's the reason. Would you rather have an infection control led from office or from the front line? That's up to you. This is my slide. So definitely if you see the pros and cons, the pros goes to the nurses because they take immediate action, proactive patient care versus delayed response and reactive analysis. Second argument is of me is when second matters, nurse don't wait for permission. A delayed 6 hours treating sepsis increased mortality by 8%. All infection control experts are here. They will agree with me. A missed hand hygiene opportunity can introduce lethal bacteria. So nurse don't wait, they act. If the patient shows signs of infections at midnight, does the nurse wait for the ICU for the morning meeting or briefing? No, they start infection control measures immediately. So nurse-led IPC model in Johns Hopkins, you can see there is a study in Johns Hopkins Hospital where bedside nurses led the authority to stop procedure if infection risks were identified, where they were able to reduce the infection rate by 30%. Why? Because nurses don't ask permission, they save lives. Now comes to argument 3. Rules don't save lives, but compliance does. Reality in hospital where IPC led by an ICO, compliance with infection control rate is 60 to 70%, less effective in real-time accountability. But when it's led by the nurses, it compliance jumps to 90 plus and effective real-time accountability. Why? Because nurses hold people accountable in real time. Surgeon skips hand hygiene, nurse stops them. A staff members wear a wrong PP, nurse stop them, correct them. A catheter dressing is not sterile, nurse replaced it immediately. So let's be honest, nurse don't listen to ICO's PowerPoint. I think because if you see when there are meetings are there, doctors usually they don't like to attend the meetings. They are very passive when it comes to the meeting. And they don't like to see the PowerPoint, but they will listen to the nurse who calls them in the operating room. So nurse don't just recommend infection control, they enforce it. And that's the difference between ISO and nurse. Now, fourth argument which I have it as patient safety shouldn't be a passive role, but it should be an active role. ISO is like infection control officer is a consultant, but nurse is a warrior. If you see a fire starting in your hospital, will you wait for the fire safety consultant or fire safety officer, or do you grab an extinguisher and put it off? So infection control is exactly the same. Nurse doesn't wait for a report, a nurse takes action. In hospital with doctor-led IPC model, an undetected MRSA outbreak spread across multiple units. So ICU analyze the data, identifies, write it, everything. But nurse takes action. They want to stop the outbreaks. They will work on the if you see Dr. Merlin was talking about the antimicrobial stewardship program. But overall, if you see in the hospital, this program is led by the nurses. They look at this antibiotic prophylaxis, timely administrations, or they see that if doctor prescribes a antibiotic which is not warranted, they stop them. So the success of antimicrobial program is depend on how the nurse is empowered. So this is just not about the title, but it's about saving lives. When it comes to the infection control, it's saving the life. Again, every patient is someone's mother, father, child, and best friend. So every infection is too many. So every second is a chance to save life. Nurses are not just a caregiver; they are warrior against infections. So we don't have a time for discussion. Usually, we don't spend that much time on infection discussion, but we leave at all the stake, or we leave it. We actually, if you see, we breathe the infection control, and we see to that who will act first, and we want to act first and then analyze. Definitely analysis is important, and if you see the nurses with lot of training, they have been they know how to analyze the data, they know how to do the root cause analysis. There are, if you see, a lot of study shows in the abroad, lot of hospitals have been led by the CEOs, or the nurses led the hospital, and those CEOs are the nurses. Initially it was not like that. So I think it's a time has come to change the perspective about the nurses, because yes, ICO has the knowledge, but the same knowledge nurses have it. There are a lot of trainings have been available. There are a lot of upskilling programs are there for the nurses. And definitely, when they have the bedside knowledge, they know what are the constraints at the bedside. And with this knowledge comes, I think, nothing like it than the nurses led this program. So we nurses fight, fight, fight till we win for the infection control. Thank you very much.
Fantastic response, Akanksha, as always. And before I ask Dr. Merlin for rebuttal, I just want to put it out here that both Akanksha and her mentor, both Mrs. Gracie Matai, both of them have been the C-suite. They have been chief operating officers, CEOs, and they have been a role model for many of the nurses. And like what she said, looking at them, definitely the perception and the respect for the nursing professions itself has changed, at least in our part of the country. That said and done, let me invite Dr. Merlin for a rebuttal. And before you go, Merlin, I just want to summarize how Akanksha was responding. So you had put forward three major things. One was about the knowledge gap. Second was the strategic vision, and third was involvement in certain aspects, clinical aspects like stewardship, etc. So for the knowledge aspect, as she has illustrated, the thought process was that yes, that can be acquired because it is there as smart as anyone else, so it is possible. From the strategic vision perspective, it was told that execution is extremely important rather than just the strategic vision, and hence it would be more beneficial. And last, you had also put forward the bias thing, so maybe that's something which is not fully addressed, but I will come to that once your rebuttal is done. So, Dr. Merlin, if you have any rebuttal, please go ahead.
Yes, yes, definitely I have rebuttal. So, Akanksha, thank you for that excellent insights of a nurse-led program. But as I had the disclaimer in the beginning, that, I acknowledge that nurses are the key ingredients of the program, and they do this at the grassroots level. But I was purely talking about the governance part. So it is the team is, the program will not run its best course without the nurses, but it's not just the nurses. You have to include the other healthcare workers as well. The penetrance will be much better if the governance comes from an infection control officer. So, like the bedside tales, the bedside, patient friendliness, everything else, no one can replace a nurse. However, from the governance part, the leadership part plays a key role where the change comes in. So there is I had actually the knowledge part, which I was concentrating, was not regarding the basic knowledge of the infection control and the surveillance. As we are evolving in practice, we have newer bugs and we have newer things added into the infection control. So the knowledge of your institution or the team has to be led by an infection control officer, and this makes the knowledge more reliable. And it doesn't mean that the nurses are not knowledgeable. However, when it comes from a person who is trained to deal with the newer emerging bugs, the MDROs and all, it will have a new angle, which will lead to faster response times as well. Now, regarding the second point was, Anup sir, regarding, I think that is regarding the
strategy versus execution.
Yeah, strategic execution. So so what I was trying to tell is that when a nurse-led program is in charge of uh, a group of healthcare workers, where majority of the healthcare workers are nurses itself, there is a chance of bias. And when this happens, there is a chance where the CAPA, the corrective action and preventive action, gets diluted as well. Now, in most of the cases, there is a chance that the non-compliance from the grassroots level nurses are being will be downplayed by the nurse-led team, and this would be better. And more strategic action plans will be led forward if an infection control person, infection control officer, is in charge of this non-compliances. So, and the third thing about the bias I had already mentioned. So the chances of bias, including the bias which will lead to a risk of decreased objectivity, the breaches in protocols which may be happening at the nurse level itself, will get diluted when nurse-based governance is in action. So let me end this by this saying that at grassroots level, the nurses may be doing their best part. However, maybe this could be better when the ICO is at a governance level. Thank you.
So
thank you, Doctor. Yeah, Dr. Anup.
Akanksha, can I have your rebuttal also? So the final last
Yes.
thing from her is the bias part. If you can specifically address that bias part, and then we'll go for a poll, post-debate poll.
Yes.
Thank you.
So when it's no, 2-3 things. One is like definitely I have seen that some comment was there that nurses are not good in decision making. No, please, I want to take it this back, because see, that's what I want all of you, as rightly said by Dr. Merlin, that we need to change our perspective. Things are changing. Nurses, I told you, there are good hospitals have been run by the nurses. There are, and I think in India, very few, but in abroad, a lot of hospitals have been run by the nurses. Why? Because they feel they are a very good decision maker. Why they are a good decision maker? Because they know what is happening at the grassroots. What you told Dr. Merlin, at grassroots, they know the grassroots reality. They know how to and where to plug those holes and how to control everyone and get them on the place. So that's the reason. Yes, it's very important that they are the very good decision maker, and a lot of decisions which are made by the nurses have been, because as I said again, the decisions, the strategies which are made in boardrooms are actually difficult to execute. That's the reason we always say that when we want to make a strategy, we want to involve the ground staff. And I think no better than the nurses can be a ground staff, because they know they actually deal with all the team members. And as rightly said by you, Dr. Merlin, it's a teamwork. But who anchors the team on the ground? Because see, infection control officer can make a strategies, everything, but they are not there on the ground. On the ground, the nurses are there who anchor entire team. As I said, it's a teamwork. But if somebody is not wearing a PP, she will stop. If doctors is prescribing wrong antibiotic, she will stop. She or he. Sorry, there are a lot of he's are also there in nursing. Or if doctors are not washing the hands, he or she will stop them. So that's the reason that's very important. Now, when it comes to the biases, yes, that is what you told. It can happen, but the biases is depend, because these biases can happen at the infection control officer level also, in biases in taking the decision by not having the ground reality knowledge. And that's the reason these biases can change your decision. But nurses, they know what's the ground reality. That's the reason when they do the root cause analysis, they know exactly where things have gone wrong. And small things I can tell you, which your eyes, usually we tell that what your brain knows, your eyes can see. And nurses are working at the ground. So that's the reason their brain knows where the things are going wrong, because they are working with the patient day in, day out. They know what things have gone wrong, and because of that, why patient has got an infection. And that's the reason, definitely when doing the root cause analysis, these biases will be taken away, because they know where the things have gone wrong. This is what I buy better is, Dr. Anu.